Hey, it's working. We have a couple more minutes. All right, folks. So this is our first official training for the 12th scope of work and the nitty gritty of some of the things that we're doing. It's kind of exciting, right? I hope someone's excited because it's CAUTIs and CLABSIs. I'm excited. That's the IP in me.
You know what, Melanie? I think it's a nice little break from contact updating and outreach and just all kinds of other things that are going on. So I'm excited too.
I know. Actually, to talk about something that we're going to be doing and something that matters so much, right? Um, and so it's 2 o'clock. So this is again one of the first trainings that we're starting. We kind of throughout the next few weeks they're kind of scattered around. Tomorrow I'm going to do a nursing home one. There's something next week. Pressure injuries, I think, are next week. And Dr. Guilfoyle is interested in doing what, SSI, surgical site infections?
Yes, and I think I'm going to be presenting on emergency department wait time.
Okay. So that's going to be in a couple weeks. So some more trainings. So two different ways we're going to do the trainings. We're going to do some live trainings for you to be able to ask questions. We're also developing training programs. Ann Merka really has been the key organizer for that. And so we're doing PowerPoints, and it will be in the learning management system. And we'll also do office hours on topics that we'll be working on that maybe you're not familiar with. But again, today we're very excited. Dr. Guilfoyle is working with us and was willing to do a presentation on CLABSIs and CAUTIs. So I am going to turn it over to you. Thank you.
Okay, great. Can everybody hear me okay? Okay, good. Hi again. Thank you for that introduction, Melanie. My name is Dr. Danielle Guilfoyle. I am currently working at Stony Brook University as a preventive medicine resident. So I'm working with iPro as part of my training, and I'm happy to be here today and give you guys an overview on some prevention about CAUTIs and CLABSIs. So I'm going to share my screen. Okay, can everybody see the PowerPoint?
We can.
Okay, great.
Do you prefer people to hold off with questions or ask questions throughout the?
Yeah, I was going to say, in the essence of time, I think if I get through the presentations and if everybody has a question, if they want to jot it down or put it in the chat, and then at the conclusion, we can kind of go through the Q&A session. That sounds good? Okay, great. So first, I'm going to do some presenting on catheter-associated urinary tract infections, also known as CAUTIs. So our clinical aim is patient safety, infection prevention and control in facility-wide inpatient hospitals, so the acute care hospital setting. So the overall goal of this training is going to be to provide a broad introduction to the topic, to prepare staff with the basic knowledge and resources to provide one-to-one quality improvement technical assistance to providers. This basic training presentation is not comprehensive and will not cover every quality improvement scenario or resource that may be available. Please remember that staff are supported by AIMS leads and clinical subject matter experts, and they should be contacted with any additional questions you may have. So this is just a little bit of the training overview that we will do today. So there is a pre-test and post-test that you'll have access to at the conclusion of the training. Overall, in this training, We're going to learn why this topic is so important and receive an overview of the clinical evidence base and significant research, clinical topic details, and best practices. We're also going to talk a little bit about why this topic is problematic to manage and the implications for individuals and public health. We're going to talk about CMS QIN-QIO 13 Statement of Work requirements for this topic, receive an overview of related metrics by which CMS will evaluate the work, and know the expected improvement target goals and when they need to be achieved. Healthcare providers are impacted by other federal programs with measures that are the same or similar to QIN-QIO measures, so it's important to also be familiar with things such as MIPS, which stands for Merit-Based Incentive Payment System measures that are used by Medicare to evaluate quality, and also HIDIS, which is Healthcare Effectiveness Data and Information Set measures, which are used by health plans, government programs, and others. So we're also going to talk about an action plan for this topic area that will help everyone to provide resources and identify appropriate interventions for CAUTIs and process measures for improvement. So first, this is just a little bit about Health and Human Services. So they have identified reduction of healthcare-associated infections as a priority goal. So this includes a lot of infections, CAUTI, catheter-associated UTIs being a major one. And this is defined, healthcare-associated infections are defined as any infection a person gets or a patient gets while they're receiving healthcare for another condition. So this can happen in healthcare facilities, including hospitals, ambulatory surgical centers, end-stage renal disease facilities, and long-term care facilities. And they are important because they are a significant cause of illness and death. So at any given time, about 1 in 31 inpatients have some sort of infection related to hospital care. And this is something that we can prevent. So this is why this topic is so important. So getting into a little bit about what catheter-associated urinary tract infections are. So also known as CAUTIs for short. So they are the most common hospital-associated health infection. So about 70 to 80% of these infections are attributable to an indwelling urinary urethral catheter. It's also, catheter use can also be associated with things like inflammation in the urethra, urethral strictures, any kind of mechanical trauma to the anatomy in the area, or also mobility impairment. The length of time that a catheter is in place contributes to the infection. So this is the major thing that we want to emphasize, is that limiting catheter use and duration are the most important ways to prevent infection. So an educational intervention, including catheter indications, timely removal, and correct management, along with the initiation of active surveillance, have shown decreases in catheter use and CAUTI rates previously. So we want to continue this and increase it in order to further decrease those CAUTI rates. Among UTIs that are acquired in the hospital, there's approximately 75% that are associated with urinary catheters. So that is a majority of UTIs that are being contracted in hospitals. About 13,000 deaths each year are attributed to UTIs. They are associated with increased morbidity, mortality, increased hospital costs, and increased length of stay. And many of them are preventable with implementation of prevention practices. In addition, we're going to be talking mainly about indwelling urinary catheters, but there are also other methods of catheterization like suprapubic or external and intermittent catheterization. So one of the things that catheterization causes is bacteria in the urine, but that is not technically a UTI. So bacteria can be present in the urine, but in order to diagnose it as a CAUTI or a catheter-associated UTI, you must have symptoms in addition to that positive urine test showing some kind of culture in the urine of bacteria, or as we'll see probably on the next slide, Candida can also be a cause, which is a fungal infection. Overall, intermittent catheterization is typically preferred over indwelling catheterization because there's fewer mechanical complications and less damage to the anatomy in the area. And a definition for the different types of UTIs is they can be caused by extraluminal or intraluminal. So an extraluminal infection is going to occur when the entry of bacteria into the bladder occurs from the biofilm that's actually in the catheter that's inserted into the urethra. An intraluminal infection occurs due to some kind of urinary stasis because of drainage failure, some contamination, or an ascending infection. So both of these types of UTIs can be prevented, and that's what we're going to talk about going further. So again, the technical definition of diagnosing a CAUTI is a urinary tract infection where an indwelling urinary catheter is in place for greater than 2 calendar days on the date of the event, with the day of the device placement being day 1. And the way it develops is bacteria, which can be from the patient's own gut flora or some kind of external source when the catheter is being inserted, can enter the urinary tract via the catheter. And it could be extraluminal, like I had just mentioned, or intraluminal, meaning it's from the catheter tubing itself. So some common pathogens that cause UTIs in general are E. coli, Klebsiella, Pseudomonas. So these are all gram-negative bacterium. And then we can have gram-positive bacterium, most common being Enterococcus. And then, as I mentioned before, you can also have a fungal yeast infection cause UTIs with Candida. Some risk factors to look for in patients that will increase their chances of contracting a UTI from a catheter. Number 1 is the prolonged catheterization. That's the single most important risk factor. And this is something we can control. So that's really important in preventing these. Some other risk factors that aren't always in our control are female gender of the patient, older age, diabetes, and then also not maintaining a closed drainage system with the catheter, and also any errors during catheter insertion or care. So again, there's a lot of repetition with this, but this is the most important thing to take away from this, is that the cornerstone of CAUTI prevention is to avoid unnecessary catheterization and to remove the catheters as soon as they are no longer needed. In addition to the risk factors, I just wanted to mention some complications of CAUTIs include sepsis, bacteremia, and even death. So I think in the beginning of the presentation, we mentioned 13,000 deaths are attributed to UTIs per year. So this is definitely something that can be deadly if not taken care of soon. So very important to prevent. The symptoms that usually must be present and are commonly seen with UTIs. So in addition to that positive urine culture with the bacteria or Candida, we want to see flank or suprapubic discomfort, costovertebral angle tenderness. So that's like in the lower back on either side. So the diagnosis can only be made with symptoms in addition to that positive urine culture. So these are some CDC recommendations for CAUTI prevention. So these are the things that are important to advise healthcare providers and healthcare staff and workers to be doing to prevent CAUTI and decrease their rates. So we want to have appropriate use. So only insert catheters for the appropriate indications and leave in place for only as long as necessary. Consider alternatives like intermittent or condom catheters, which are external whenever possible, and avoid using catheters for incontinence management, which is incontinence management, if you're not familiar, is just if somebody cannot urinate on their own. Proper techniques, so insertion and maintenance, so ensuring an aseptic technique and sterile equipment being used for insertion, maintaining closed draining system at all times so there's no breaks in the system with the catheter and the bag, the collection bag. Keeping the collection bag below the bladder and not letting it touch the floor because that could possibly contaminate the system. And emptying the bag regularly using a separate clean container for each patient. And then things that you want to definitely avoid is do not screen for or treat asymptomatic bacteria in catheterized patients. So again, that's if there's bacteria present in the urine and a urine test comes back positive for either bacteria or candida. Unless the patient has symptoms, you're not going to treat that. And you're not going to constantly screen for it either unless the symptoms are present. Do not use routine antimicrobial prophylaxis, because this can add to the problem of antibiotic resistance with these organisms, and then also not changing catheters at routine fixed intervals. And then some things that administration can do and QI support is implement quality improvement programs with alerts and reminders for catheter removal, ensuring education and competency of personnel, and conducting surveillance of CAUTI rates and providing feedback to their clinical staff. So for some treatment guidelines and managing any recurrence of CAUTIs, the first thing you want to do is assess the catheter. So this is a critical step to see if a patient needs a catheter. If it's not medically necessary, it should be removed. If it is still needed, it should be replaced. So if a patient has an indwelling catheter and they come back, they have symptoms of a UTI, and then they also have that positive urine culture, you're going to start treating the patient with most likely antibiotics, but you want to remove that indwelling catheter because there's a biofilm that forms on the actual catheter in the urethra, and that can make the infection very difficult to treat. So that should come out and be replaced if they still need the catheter. Again, treating symptomatic infections only. So we're not going to be treating any asymptomatic bacteria. In addition to the symptoms I mentioned for UTIs, which is usually fever, the suprapubic tenderness, or lower back pain, if they have any systemic infection symptoms, that can count towards this being a diagnosis as well. So even if it's not that specific, but they have other symptoms that would maybe signal sepsis is going on or some kind of systemic blood infection, you would also treat for a possible UTI. Antibiotic selection. So treatment is going to be individualized and guided by the local hospital programs, and then also specific culture results and sensitivity results that come back with the urine culture. But most common first-line antibiotics that are treated, that are used for treatment for CAUTIs are going to include fluoroquinolones like Levaquin, Cipro, nitrofurantoin, also known as macrobid, and then trimethoprim sulfamexazone, also known as Bactrim. Duration of therapy, usually if it's not a complicated UTI and it's basic, the patient hasn't had many UTIs in the past, a 7-day course is sufficient. Sometimes longer courses are needed, 10 to 14 days. Again, usually oral treatment is going to be fine. If it's a more of a severe illness, then they may move it to intravenous or IV treatment. And managing recurrence, recurrent CAUTIs are going to require investigation. So this is going to include ensuring that the initial infection was treated appropriately, the medication was completed, the whole course of medication, reevaluating the indications for the catheter, and considering underlying urological issues. And this may need to consult an infectious disease specialist or a urologist to kind of get down to the bottom if a patient is constantly getting these infections. So this is some information on something that the CDC provides called a Targeted Assessment for Prevention, or a TAP strategy. So it's a framework for healthcare and public health professionals to prevent healthcare-associated infections like CAUTIs, and the tools are free and available for download online. This support is provided to healthcare facilities, health departments, hospital associations, and other partners that want to use this strategy. So the 3 main components are target, assess, and prevent. So target is going to be identifying the healthcare facilities and units with the greatest room for reducing their rate of catheter-associated urinary tract infections, assessing a facility's infection prevention policies, practices, and seeing where there's area for improvement using the TAP facility assessment, and then tailoring interventions to address the gaps and prevent future hospital-associated infections. So the different sections include things like training and audits, information on hand hygiene, contact precautions, antibiotic stewardship, early detection, isolation, environmental cleaning. And in this presentation, I do have the information on where to access this. So it's a great resource to provide to hospitals, healthcare professionals in order to better their program for preventing these hospital-associated infections. So hospital-acquired condition reduction program is a value-based purchasing program for Medicare that supports the link between Medicare payments and healthcare quality in the inpatient hospital setting. So it is basically basing reimbursements on performance and quality of care. So for CAUTI infection rate, it's one of the measurements that are included in the score for hospitals. And there's a top 5. That is one of the top 5, as you can see on the bottom of the slide. So it's really important, and it's likely that hospitals already have a program in place to prevent and reduce CAUTIs. But we can help by providing additional resources and potential ways to improve these existing programs. And the QIA should ask the provider about their recent cases to determine how iPro can help. So these are the 5 major categories. So CAUTI is one of them. CLABSI I'm going to be talking about next. And then we have surgical site infections, MRSA infections, MRSA, and C. diff infection. So if a hospital is not doing well in any of these areas, they're going to be dinged for it and not have the highest amount of reimbursement from Medicare. So it's really important not only for patient safety to be performing well in these areas, but also on a cost-effective side of things. So CMS expectations for executing the required tasks require use of the A3C, which is assess, complement, coordinate, and create. So the design framework is called IDF, and the associated resources with which we refer to are CMS IDF resources. So that's going to be on the upcoming slides, some resources that CMS wants used to help solve these problems and create an overall quality action plan. So staff can work with providers to create these action plans to implement improvements in these hospital-acquired infections. We created 2-page summaries of all of these relevant resources. So we will have links to them and information on where to get them as well. So the next 3 slides are just going to show, well, the next 2 is screenshots of these IDF tables provided by CMS. And then the third, I'm going to have listed the resources specifically that can be accessed to create action plans to further prevent CAUTIs. So there's 5 domains and multiple potential quality improvement activities that are associated under each domain. And these are very good to become familiar with for recommended interventions, and many of them can be incorporated into action plans. So we have the different categories are governance, system design and policies, process, workforce, and individuals, caregivers, and communities. And then these are all of different resources specifically to the specific health care-associated infections that you can access to get further information on forming action plans. these are the specific resources for CAUTIs. The first one is Toolkit for Reducing Catheter-Associated Urinary Tract Infections in Hospital Units, an implementation guide. So that is specific to CAUTIs. And then the ones listed below are not specific to CAUTIs, but are still very helpful. So antibiotic stewardship programs, since antibiotics are being used to treat CAUTIs. I also included the long-term care facilities one, the third bullet. Even though we're talking about inpatient hospitals today, it's a big problem. CAUTIs also in long-term care facilities. And then other ones that are included are team steps, candor, and then practical tips and strategies for the isolated infection preventionist. So more specifically, CMS's QIN-QIO and quality measure acute care hospital definition. So they define the numerator as the total number of observed healthcare associated CAUTIs among patients in beds in inpatient care locations. This is going to exclude patients in neonatal ICUs. And then the denominator is the total number of predicted healthcare associated CAUTIs among inpatient care locations under surveillance for CAUTIs during the data period. And then here we have some of the facilities that are considered acute care hospitals and different characteristics that are considered. And then for the denominator, there are certain exclusions. So these examples are not considered indwelling catheters by NHSN definition. So suprapubic catheters, condom catheters, in and out catheterizations, nephrostomy tubes. So they are not considered indwelling catheters and therefore would not be added to the denominator. Overall, the CMS target goal is to reduce the relative improvement rate from baseline by 50%. So they want to see where the baseline is now of the CAUTI percentage. They want to see that reduced by 50%. This is a slide with some information on the Joint Commission. So if you're not familiar with the Joint Commission, it is an independent, non-for-profit organization that accredits and certifies nearly 22,000 healthcare organizations and programs in the United States. It's recognized nationwide as a symbol of quality and reflects an organization's commitment to meeting certain performance standards. So this is something throughout the United States that all hospitals must be submitted to. And the Joint Commission identifies the prevention of these HAIs as a major priority also. So for acute care hospitals, the Joint Commission statement and requirements regarding CAUTIs are focused on implementing evidence-based practices to prevent indwelling catheter-associated urinary tract infections. So again, most of the things we've already discussed, but limiting use and duration. So constantly making sure that if a catheter is no longer needed, that it's taken out and that it's not given in the first place when it's not needed. Proper insertion and maintenance. So making sure that there's sterile techniques for insertion and having procedures in place for proper catheter care. And then consistent ongoing data collection and analysis. So hospitals are expected to monitor their CAUTI rates, analyze their data, and use that information to further guide their prevention efforts and quality improvement projects. So on our second to last slide, we're going to, for this CAUTI presentation, we're going to just go over what we would do in this scenario. So if we had a medical surgical unit with a higher than normal CAUTI rate, how would we go about assessing it and working to decrease it? So step one, we're going to identify the gaps. So we would assist the unit in conducting a root cause analysis of the recent CAUTIs. So find out, why are these happening? Is there any specific characteristics going on that are out of the ordinary? So you would review charts. Were insertion indications appropriate? How long were the catheters in place? You would observe the practices or the staff following the aseptic techniques for the insertion. Is proper maintenance being performed? And then also interviewing staff. Do they know the criteria for insertion, and do they feel empowered to ask for removal orders? And then after that, after the root cause analysis is conducted, you would move on to step 2, which would be provider implementing interventions. So re-educating any staff that needs it on appropriate indications for catheterization and proper maintenance techniques, implementing a nurse-driven protocol for catheter removal, adding a catheter check to daily nursing assessment, which is going to force a daily review of necessity, and then providing unit leadership with weekly data on the utilization and quality rates. And then finally, in step 3, we would measure and track progress. So monitor the catheterization utilization ratio, how many catheter days over total patient days, monitor the standard infection ratio of qualities, and then perform audits on the insertion maintenance practices and adhere to the removal protocols. So in conclusion, this AIM topic-related office hours will be scheduled weekly to assist staff in implementing the AIM-related interventions. And AIM's lead and clinical subject matter experts are available to help. And then don't hesitate to reach out with any further questions or concerns. Thank you. So I think if everybody is okay with holding questions and maybe just putting them in chat or jotting them down, we will move on to our second topic, CLABSI. This one won't be as lengthy because there's a little bit of overlap and also some repeat slides on some of the details with CMS and such. So same clinical aim. So we're talking about patient safety, infection prevention and control. And now we're going to be talking about, once again, inpatient hospital setting, but we're going to be talking about central line associated bloodstream infection, also known as CLABSI, in the acute care hospital setting. So this is going to be the same overview. This also has a pre-test, post-test that you'll have access to at another point. And then we're going to talk about why this topic is so important, topic-related metrics, and then the interventions on this topic. This is a slide that is repeated, talking again about the Health and Human Services, and that CLABSI now is another healthcare associated infection. That's one of those top 5 that's really important. So again, this is an infection that people can get while receiving healthcare for another condition. So what is central line associated bloodstream infection exactly? So a central line first, or a central venous catheter. So this is a tube that a doctor places in a large vein, either in the location of the neck, chest, or groin, to give fluids, blood, or medications, or also to do certain medical tests. So specifically, a CLABSI is a laboratory confirmed bloodstream infection. So this is where a central line was in place for, again, greater than 2 calendar days on the date of the event, with the day of device placement being day 1. So in order for this to be recognized as a CLABSI, the patient must have a recognized pathogen cultured from 1 or more blood cultures, and the organism cultured from the blood must not be related to any other infection site that's localized. Common pathogens with CLABSIs include Staphylococcus aureus, which includes MRSA, coagulus negative staphylococci, enterococcus species, candida species, and then the gram-negative bacilli, the Klebsiella, Pseudomonas, and E. coli. So as you can see, there's a lot of overlap between the organisms causing these infections and also the CAUTI infections. Just some additional numbers to get an idea of how big of an issue these infections can be. In 2022, there were about 24,000 CLABSIs reported by about 3,700 United States acute care hospitals to the CDC. And among these infections that were reported, about 9,600 occurred in adults in the ICU. About 12,500 were in the inpatient wards, and about 1,200 were in neonatal ICUs in the United States, and that was in 2022. Approximately 15 of the cases occurred in children, and approximately 51% of cases occurred in the ICU. In addition, indwelling catheters are also a frequent source of infection in populations requiring long-term venous access. So this can include hemodialysis and oncology patients that are going for dialysis treatment or chemotherapy treatments, and also those receiving total parenteral nutrition. So for the risk factors for this infection, again, there's going to be some overlap, but prolonged hospitalization before the catheterization, so being in the hospital longer before you had the central line placed, prolonged duration of catheterization, greater than 7 days, you're at a higher risk to get a CLABSI infection. Heavy microbial colonization at the insertion site, so basically the area not being sterilized and cleaned before inserted. Internal jugular or femoral vein catheterization sites. So optimally, the subclavian vein is going to be the safest site for insertion of these central lines. Neutropenia, which is a low white blood cell count, so that leaves the patient susceptible to infection with a lower immune response. Prematurity in infants, suboptimal catheter care, so poor hand hygiene before insertion, and then inadequate dressing care after insertion, failure to adhere to insertion practices like barrier precautions with PPE during insertion, and also, of course, any catheter hubs that are contaminated during insertion. So the prevention guidelines from the CDC have identified 5 core interventions in order to prevent these CLABSI infections. So hand hygiene, so washing the hands adequately before and after touching the catheter. Maximal barrier precautions upon insertion. So you're going to want to have full PPE with a body drape, sterile gloves, gown, cap, and mask during insertion. Chlorhexidine skin antiseptic being used during insertion, so cleaning the site with alcohol before the insertion. Optimal catheter site selection, so avoiding the femoral vein and the subclavian being the site that's preferred, as I had mentioned before. And then daily review of line necessity, and then prompt removal if it's unnecessary. So this, again, is the single most important intervention to reduce the CLABSI risk, removing a line that's no longer essential. So this has that in common with the CAUTIs, and it's something in our controls, which is great because we can then bring down the percents of these infections happening in hospitals. Some additional strategies that are used for prevention are proper hub connector care, so making sure that area is clean before insertion. Using antibiotic impregnated catheters. This is going to only be in high-risk populations that require that, though, and ensuring that lumens are flushed routinely after placement. And then just one additional fact about central lines. So all of them have some sort of risk of infection, but some have a higher risk than others. So non-tunneled central venous catheters carry a greater risk than others, like peripheral venous catheters. In addition, the skin microbiome is an important source of IV catheter infection. So staphylococci are common to be on the skin. So during insertion, that's something that can be introduced to the bloodstream. So that's why the sterile procedure is so important during insertion. And Candida is actually, which is the fungal infection, is the most common central line associated infection in adults in the ICU. So that's something to be mindful of. Okay, so this is a little bit of repetitive as well, but the CDC Targeted Assessment for Prevention, or also known as TAP, also has specific strategy for CLABSI. So again, as I had mentioned before, this is freely available for download, and it basically is going to go through the same thing, but now specific to CLABSIs. So targeting the units with the greatest room to reduce the CLABSIs, assessing their policies that are already in place, and then seeing where there's room for improvement, and then preventing by tailoring the interventions to what the specific issues are in those hospitals. This again is talking about the hospital-acquired condition reduction program. So as I had mentioned before, Medicare reimbursement is often based on numbers like this, on these healthcare-associated infections, CLABSI being one of the big ones, in addition to CAUTI. And so this is why this is so important to decrease, not only for patient safety, but also for cost effectiveness and optimal reimbursement from Medicare. This is, again, just some of the CMS requirements. I won't read it again because I know I went through it before, but using that assess, complement, coordinate, create, and then also the IDF resources. So specific resources that can be accessed for CLABSI prevention, I have listed here. So some of them, the ones that aren't highlighted are repetitive. So these were also in the CAUTI presentation. But the two specific to CLABSI are a toolkit for reducing central line associated bloodstream infections, and then how to prevent central line associated bloodstream infection. And the same thing with these resources. We have the 2-page summaries that basically gives you the gist of the important strategies that can be used. These are those same tables, including all of those CMS approved resources. And now for the specific definition for CLABSI, now for CMS QIN-QIO quality measure, acute care hospital. For the numerator here, we're going to be talking about the total number of observed healthcare associated CLABSIs among patients in beds in inpatient care locations. And the denominator is the total number of central line days for each location under surveillance for CLABSI during the data period. And then this has specific denominator exclusions as well. So there is a bunch of different types of central lines that are not going to be included in this. So just a couple here: non-lumen pacemakers, arterial catheters. I won't read them all, but these are things that are not going to be included. And then the target goal is the same. So reducing that relative improvement rate from baseline by 50%. This is again emphasizing the Joint Commission. So they also are big on preventing CLABSIs as well. And a lot of the prevention techniques that are recommended are similar to CAUTI's. So limiting use and duration. Central lines should only be used for appropriate indications and should be removed as soon as they're no longer needed. Proper insertion and maintenance. So hospitals need to ensure that staff are educated and following the sterile techniques for central line insertion and have procedures in place for proper care. And then consistently collecting data and analyzing it. So monitoring the CLABSI rates, analyzing it, and then using the information to guide further prevention efforts and quality improvement projects to decrease those CLABSI rates. For this intervention scenario, again, a medical ICU that has a higher than expected CLABSI rate. So a certain area in the hospital has a higher than expected CLABSI rate, so we want to investigate why this is happening. So the first thing we're going to do is do that root cause analysis. So we can use something like the TAP assessments that we talked about previously. And we can include direct observation of lines being inserted and then maintenance, making sure that this is all being done correctly. And if it isn't, taking notes on what is being done wrong so that you can further guide provider education. Reviewing reviewing the root cause analysis and observations, and then identifying those gaps. So inconsistent use of insertion checklists, for example, could be happening, dressings not being changed or loose or soiled, and lines remaining in place even when patients maybe don't need them and can take oral medications. So these are all areas for improvement. So going further for step 2, you want to take everything you learned in the root cause analysis and the observation period and now re-educate the staff on anything that you saw that was incorrect. On the prevention bundles like insertion and maintenance, implement a line necessity question into the daily rounds for every patient with a central line. So making sure each day it's being gone over that this patient does need the central line in place. Empowering nurses to stop a procedure if the checklist is not being followed correctly or they see anything wrong, like the procedure's not being done sterilely, and conducting audits of dressing integrity and hub care. So making sure that once it is in place, that the dressings are being properly addressed. And then finally, step 3, measuring and tracking progress. So monitoring the CLABSI rates per 1,000 central line days, tracking central line utilization ratio, so line days per patient days to ensure it decreases, and then auditing adherence to the insertion checklist and the different insertion and dressing protocols. So that brings us to the end of the CLABSI presentation and then also the end of my presentation. So thank you for listening. And then we will now transition over to any questions you may have. I'm happy to answer any of the clinical questions. And then I think Melanie is on with us also to answer any specific iPro contract questions and things of that nature. So I will stop sharing my screen.
I also put in chat an example of what the 2-page summaries would be of the IDF, and then an example of the full IDF, just in case that was helpful. Gail, I see your hands up with a question.
Sure. Thanks so much for Dr. Guilfoyle.
Guilfoyle.
Guilfoyle. Okay.
Yeah.
Thank you.
You're welcome.
I don't have a clinical background, and I am trying to conceptualize my role as a QIA and how I am going to be interacting with whether it be hospital staff or nursing home staff. And given that I'm non-clinical, I'm not concerned. I just don't know what the expectation is that you have of me to know all of these bacterium that cause CLABSI and CAUTI, all of the procedures and all the care paths that are required, that are part of that process. And so that, so we do a root cause analysis, and then there's certain steps that you had there. And I guess I'm just, Melanie, if you can explain to us really what the expectations are of us.
Yes.
Thank you.
And I think this is what you're going to possibly feel throughout some of this training. It's really giving you that baseline of understanding why CLABSIs and CAUTIs are a challenge and why we need to be looking at that. So the way we've developed the program is that, Gail, if you're going in with a facility and you're going to start doing a root cause analysis related to CLABSIs or CAUTIs, you're going to bring a subject matter expert in so that we can work with that root cause with you. So you're never going to be trying to determine or define things that wouldn't be within your comfort zone. What is in your comfort zone is that quality improvement.
Okay.
How we do quality improvement. Yes. Yeah, absolutely. So there's always the support from, okay, well, let's talk through this. Let's say, are you using chlorhexidine to scrub the hub? That's something that a nurse or IP or Terry Lebowski, one of us could get in and start saying those things to drill into opportunities, and then you can work with them to create the action plan and identify their next steps.
Okay. And I think we did, I know I did that in the last scope of work when it came to certain things. We'd bring in, you know, folks from the nursing home team to speak specifically on those issues. And I just didn't know what those, I appreciate the education and I do know CLABSI, CAUTI, I do understand that. But I think from a clinical perspective, I don't have that. It isn't like intuitive for me to say those certain words and to do all of that. And I just would never want us as an organization to be looked at like, oh, they don't know what they're talking about. So if you're saying that I'm going to have a SME or you or someone else who does have that clinical background, then I have no problem with that. But I just didn't know how we were being,
Yeah.
what the expectation was. Thank you.
And we may find that we need to actually do more learning circle type of thing. So we have a whole group of hospitals that are working
Okay.
through this particular problem. So we may have to develop a little bit more of those affinity groups, and then the content is from the SME, and then the follow-up will be with the quality improvement advisor. So
And just another quick question I had about, you know, we were talking, I would think it would be for both CLABSI and CAUTI. Um, when you were talking about the different types of catheters that are used. Now, I probably have been cathetered, I'm sure at some point when I've had different surgeries, but I don't have the visual of the difference between an indwelling catheter, a subpubic or whatever. I think that was what it was. And is there something that we can look at so that from a visual standpoint, I can maybe understand why one would be preferred over the other? Is it's because of where it's, how it's inserted, where it's located, that just from a need to know so that I can put my head around it.
Yeah, I don't know if the resources that were listed, if they're going to have pictures, but I agree, a picture is worth 1,000 words, that you'll
Yeah,
definitely be able
yeah.
to
I'm a
see.
visual.
Yeah, I think for the purposes of the presentation,
Okay.
the pictures were, um, they take approval to get in there, so that's why they weren't there. But yeah, I would say if you just did a search online or anything that's CDC related or
Okay.
can show the differences. But yeah, but basically, the like condom catheters, the external ones are not invasive, so they more sit on the outside and they're used for the females. I don't know if they have for males. They may have them now for males as well. And they're probably going to be used if somebody has to use them on a longer term basis.
Okay.
So you don't have that indwelling catheter in too long to increase your risk for infection. In surgeries, most time, I still think they're using the inserted ones.
Okay.
Yeah, because that's just temporarily being put in and taken out at the end of the surgery. And then anything that's needed for long term, I guess that would be individualized to the patient situation and based on what the providers want. But yeah, I think I agree that seeing the different types of the catheters would be helpful.
Yeah. Thank you.
I think that's good feedback, Gail, too, so that we can do some of that. And we do
Okay.
plan to host some office hours as well, so we could
Okay.
show you. I mean, we can get in depth. It's really about what level you want to be, and we typically just think anything indwelling, we want to get it out, right? Because
Right.
anything indwelling heading into the body is a pathway for germs to enter in. So
Okay.
indwelling urinary catheters gotta go.
It makes complete sense. And then just one last question, since I have the floor, is the issue of, you know, I think one of the first lines, whether it be for whichever catheter or yes, that would be used would, who determines the need for whether it be indwelling, subpubic? And I understand, like most of the time, I'm sure if you're going in for surgery, it's going to be indwelling. But then have hospitals and providers begun looking at different methods rather than that being their standard plan of care as part of a procedure or something? So that's just another thought I had in my head.
Yeah, I think that they have really expanded and developed a lot of these different catheters to solve the problem of the indwelling. One of the resources, I don't remember the exact one, I think it was one of the CMS resources, but it was very extensive and they went into, I didn't include it in the presentation because I didn't want to make it too long or too much extraneous detail, but they went through in very detail the different requirements for the different types and also whether you should have a catheter at all. So that's
Okay.
really important because not only making sure that they're being properly used, but if a patient doesn't need it in general, that'll
Right.
really cut down. So yeah, and I think the decision falls mainly upon, probably the healthcare provider, physician, or nurse practitioner that's in charge, and the orders come from them.
Okay. Thank you.
You're welcome.
Kelly.
I kept coming off mute and then Gail kept having more questions. Gail, I was jumping in just to because I felt the way you feel right now when I was asked to be part of the HQIC contracts because it was all clinical, and I wish that I'd had Dr. Guilfoyle's presentation on CLABSIs and CAUTIs because I wouldn't have felt so lost, because it took me months to figure out that I was competent enough to come in at that ground level and to know that I had subject matter experts behind me to support me. So you are coming in where I was 4 years ago, and just know that there's a great team back there, and Carla Lisa can speak to some of those HQuake things that we encountered. But and I wanted to thank you, Dr. Guilfoyle. The presentation was fantastic, and I have to prepare to do something on the substance use disorder and depression screening. So listening to your presentation has helped me figure out how to tweak mine.
Oh, you're welcome.
That was really all. I just had a couple of comments.
Thank you,
Thank
Kelly.
you. Carla Lisa.
I was thank you for your presentation, Dr. Guilfoyle. One of the things that I think might be helpful, only because in the overview, you did make a correlation in some cases, I think particularly CLABSI, about critical care units and patients being in critical care units. And I do think right, there's kind of this overlay of the actual use of a indwelling catheter or a device, and also antibiotic usage and resistance. And I would love in the future if we could have something that would talk a little bit about how they overlay the because in a critical care unit, right, you may find that you may run into the situation where the antibiotics particularly, and the profile of, I know there's a word for this, the antibiogram, is that the word?
Yes.
Yeah.
Correct.
May have a bearing, and that would be something I think at a certain point going down the line that would be interesting to know more about.
Thank you.
Thank you.
And Terry Lebowski is PharmD, and antibiotic stewardship is her specialty. So she would be fantastic to kind of do an overview about that, Carla Lisa.
Oh yeah, I absolutely agree. And she was great in HQuIC. And we did, I know I was kind of peeking, but we have loads of the CDC TAP material, and I don't know where the folders are though, Melanie. So it's all available, accessible. And I mean, I
Right.
actually have it personally. I would like to a quick thing about TAP and my experience in the hospitals, and you can think about this going forward. The idea of taking the whole TAP intervention, we found a lot of people a little bit anxious about doing that because it can be very overwhelming to use everything. But it's like breaking down team steps. There are pieces of it that could be very good and used in a targeted focus way to do a, in conjunction with root cause analysis. So just something to think about going forward from experientially anyway.
So I just want to remind folks too that the way the 13th scope of work is laid out as our resources, majority of them have to come from that IDF. So hopefully you all have seen the PowerPoint, you've read the statement of work, you know that there is a group of resources. Our subject matter experts are going to choose some of those resources so that it's not quite as overwhelming. So that's why we have, I think we right now have 65 of the 2-page summaries. Those are IDFs that have been chosen by the subject matter experts that you can become familiar with. It's in the SharePoint site. Most of you should have access to that SharePoint site. Check and click on that link and see if you can get access to it. If you don't, let me know. We can start making sure. The first link, I see some people are looking at it. So just to be thinking that we have evidence-based tools that we're using this time. It is a little bit different than the 12th scope of work. A lot of times we were in the creation mode. We're not going to be quite so much in the creation mode. So, and I see Charlotte has her hand up and we have 2 minutes.
Yeah, thank you. Just a very quick question. You mentioned in your presentation NHSN reporting. In general, do they have to report on CLABSI and CAUTI every week, even if they don't have any cases, or only if they have cases?
I
Do
would
you know, or does
I
anybody know?
I would imagine, I don't know for sure, but I would imagine they would report even if there were no cases.
Okay.
In H-Quick, I can confirm that when they didn't report it, the reporting came out skewed. So then we had to reach out to the hospital and ask if they forgot to report it or if they actually had no cases. So I don't know if that answers your question or not.
Yeah, that's what I thought. It rings a bell, but thank you for confirming that. I just know that in the past we've had questions about COVID reporting and flu reporting, vaccinations. So it probably pertains to CAUTI and CLABSI as well. Thank you. Great presentation.
And
Thank
for
you.
NHSN, it varies per state, per setting, right? So hospitals have specific requirements, what they're reporting versus nursing homes. Some nursing homes in some states, no, let me say that differently. Some states are requiring some infections to be mandatorily reported in NHSN for nursing homes, but not all states. So NHSN has its own depending on what state you're in. All right. Thank you, Dr. Guilfoyle, for joining us, and we're excited to hear your next topic. I haven't set it up, but I know your dates that are available, so I'll be sending out an invite to everyone.
Great.
Any
Thank
last
you.
questions before we hop off? I think we're good.
Thank you
Thank
all.
you so much.
Have a good day.
Bye.